But welcome to our case conference. As I mentioned, today I'll do case conference. Tomorrow is grand rounds. Thursday is a respiratory talk with Jim Lavelle. If you've never listened to one of his talks, highly recommend. And then Friday will be another case conference with me. Scan your QR code each day. Let me know if you're having any tech issues each day, and I'm happy to get those squared away for you. So let's jump in. Today's case conference is a 31-year-old female. She has a history of stage 4 breast cancer with known metastatic disease to her lungs, bones, who had a cancer course that's been complicated by recurrent malignant pleural effusions requiring a Pleurex catheter placement. She also has a history of anxiety, and she's coming in with worsening dyspnea. She was actually in the hospital just a couple of weeks ago for issues with her Pleurex. Turns out she had a hydropneumothorax during the last admission. And she felt like she was home for the last 2 weeks, wasn't getting any better, was feeling more dyspneic and wanted to come in. You can see her past surgical history listed there, an XLAP with a bilateral oophorectomy and salpingectomy. For her meds, her cancer therapy right now is palliative everolimus and fulvestrant. She's on sertraline for her anxiety, along with some hydroxyzine and loperamide as needed for diarrhea. Her family history is unremarkable, and for her social history, she lives with her husband and kids. No smoking, no drinking, no drugs. Is just trying to make the most out of her time with her family. Any questions or other things that you'd want to know?
Fulvestrant.
It is an IV-based chemotherapy that is given in the clinic. Exact mechanisms not pertinent to her case, so we don't have to discuss. Yeah, it is like a palliative, very end of the line option for metastatic breast cancer. Okay, I'll give you the ROS that the admitting resident went through. And so the only other things that she did, mostly negative. She's not having any weakness or fatigues, no rashes or bruising. She has had some left nipple discharge, but otherwise is short of breath, no cough, no chest pain, no palpitations, pretty pan-negative review of systems aside from the initial dyspnea that she's coming in with. I will pause while you guys grab your food. Metastatic breast cancer coming in with dyspnea is the patient. Okay, let's move on to her ER course. So I'll give you her vitals and her exam. Could I have a med student point out? I think that Ravati, you're the only one right here. Settle down. So tell me when you're looking at her vitals, what's concerning to you or not concerning to you? Yeah.
Is that 32?
It is.
So it's really high. And then oh, 93% oxygen.
Yeah, new oxygen requirement. Great. And then let's look down at her physical exam. So she is well appearing. She has a regular rate and rhythm, and S1 and S2 are normal, no murmurs, good distal pulses, no JVP. Her left nipple was tender to palpation, but there was no discharge that was seen, despite the ROS describing some discharge, no swelling. Coarse breath sounds with decreased breath sounds at her bilateral bases, no wheezing. Her belly's soft. She has some left upper extremity edema, which is consistent with her lymphadenopathy or her lymphedema. No lower extremity edema, good strength, and neurologically intact. Any questions or clarifications so far?
Can I say one thing, Cassandra?
Yeah.
One of my favorite things to say when I was an intern was, it's not a fever unless it's greater than 99.5. But there's some more contemporary studies that basically suggest that the 99th percentile for a normal human temperature is actually quite a bit lower than 99.5. So I actually wouldn't classify this temperature as a normal temperature for this person. It's not a super high fever, but it's not someone who is normal.
Okay.
Sorry, did you say she always has FEMA left of her stomach?
Yeah, that's her lymphedema from her initial surgery that she had. Pleurex is fine. She only has the tube coming out. She connects herself up to the actual catheter drainage system as needed at home. Okay. And then to round out our initial set of information that we'll get, we will give you some labs. We'll go through her EKG and chest x-ray as well. before we split you guys up. I will have to say that because we have 20 people now in the room, you guys can only eat if you like exchange with the person next to you. So like while one person eats, the other person should wait, and then like you guys can switch your eating times. All right, so labs. Could I have an intern volunteer to walk through her labs and tell me your summary of the abnormalities? Any volunteers? Okay, just have to call on somebody then. Brittany, sorry, you're gonna get called on. Yep.
I don't know. If it's
Yeah.
probably all right. It's a little low, but. BMP is unremarkable other than. Bilirubin slightly high at 1.2. Like AST and ALT are slightly high.
Yep, and I'll tell you that this is within her baseline. She has newly found liver mets as well, so that's not anything new for her. And what do you make of the stuff on the last end?
Here's on my lactate.
Mhm. Okay, and if you had to put it all together, what problems would you give her at this point? And you can phone a friend if you want. You can pass it along to someone else.
Just feel like posture.
Okay. You guys want a little more information first before we start giving her diagnostic labels? We'll do her EKGs. So I'll put up an old one first. So we'll zoom in. You guys can just take a look and get a feel for what her historical EKGs have been like. Anybody want to shout out any pertinent findings?
I don't know, it looks a little bit tiny to me.
Okay, nothing remarkable, normal sinus rhythm. Here's her adamant EKG. So I'll zoom in on for you guys. And Noah, let's have you give us a general interpretation of this EKG.
And it's grossly regular.
Yeah.
Axis.
Yeah, and you can just give me your senior level read if you want.
I mean, there's like a debit on week 3 like you, but like overall, like I'm not saying any SC there's no there's a little tacky, but otherwise like.
Okay, perfect. Let's go to her EKG or chest x-rays.
But can we go compare her?
Okay.
When the older was taken,
Uh-huh.
what was the status of the hydrochloride?
Had been drained. Yeah. Had been. Status post Plerex. Why do you ask?
It's like, really understand if they're official. But I think, like, looking at this, other questions I would ask her are like, kind of sense your heartiness, like, does it get better? Does it move forward? Is there any kind of like verdict type pain?
maybe a little low voltage, but not enough to convince anybody. Maybe that's a slam dunk. Let's look at her chest x-rays before I break you guys up into some groups. So I will put them both up there and then take about 30 seconds, talk with the people at your table about what the pertinent findings are for her admission chest x-ray. And then I'll give someone the iPad. You guys can draw and point out what you are talking about on her chest x-ray. So about 30 seconds, and then I'll come here to table 1 on the left side of the room. And you guys can point out the first things that you find. For those of you that walked in late, it's a 31-year-old female, history of metastatic breast cancer who's coming in with worsening dyspnea. She has a Pleurix catheter in place for recurrent pleural effusions.
You're welcome. Oh. Oh, yeah, of course. Oh, yeah. I can't tell you. Cassandra, what's that thing on the way? Exactly. It'll be. Right where the mouse is.
Yeah, I know. I always.
All right, so we're gonna go through table by table and talk about our findings on our chest x-ray. Start off here, we'll add one thing per table, or you guys can do more. And so just talk us through what you're drawing and what you think is important to know.
Just draw the blended cosophrenic bagel.
And what are you concerned for with that?
Pleural effusion.
Great. Middle table. And who wants to add something else? Talk about larger. Okay, great. And draw the borders that you're seeing. Give us the edges. Great. So big parts, unplugged fluid, table number 3. Anything else you guys want to add? Yeah, go right there. Okay, anything else anybody has questions about? People are asking like, what is this thing here? I forgot to tell you guys because of a fun story that she also has a left apical chest tube for this hydrogen thorax that she had, in addition to her Pleurix. So she has 2 tubes on this side that you can see coming down.
We were more asking, like, it looks like it's like wrapping around.
She's just sitting forward like this. So it's not wrapping around her jaw. We're not joking her with her. But yeah, very good observation that she's kind of like sitting here. She's like very tucked with her chin in this second image. Okay, could I have one of the seniors put together her whole sort of problem representation? So 31-year-old female coming in with I'll give you the beginning. Stage 4. Breast cancer. Who presents with dyspnea. What else are you guys gonna add? Elizabeth might be the only senior who's still in here. Where's Stephanie? Oh, you're back there. Okay. I'll take anybody, one of you guys, any senior, if you want to give me a summary of her problem statement. Yep.
Concerning for new care.
Okay, anybody would include anything different, or would your problem statement be different? She's got a white count, maybe more nodules or things seen in her chest x-ray. Slightly elevated temperature, she's tacky with lactate. Are there other things that you guys are worried about? What are you worried about, Apurva?
Shock.
Yeah, so shock, due to what?
I don't know, like probably concerned for like worsening infection, because we know that she has metastatic breast cancer, but also with the increasing increases in elevated BNP, like cardiogenic shock too, if she's having maybe like a worse pericardial effusion. I say probably like those two.
Yeah, perfect. So she's a very complicated case. She has lots of tubes coming into her chest, at risk for multiple infections with this new white count. She's on active treatment for her disease and immunosuppression. So always remembering that infection is a possibility. But then I love that Porter brought up, maybe there's some component of shock, either infectious or perhaps cardiogenic or obstructive. And so just important to think holistically about his patients that have multiple etiologies of their presentation. And so as internal medicine docs, admissions for dyspnea are something that we get all the time. And so I want you guys to talk with your tables and come up with a schema for how you guys approach dyspnea. And then we'll walk through each of the tables presentations. We'll start with the middle table first because I have most people here. And then we'll go to table 3 and then table 1. But take about 2 or 3 minutes and talk through how you approach it. And then we'll come back together and talk about it.
So.
Yeah,
it's
easier
easier
to
to
figure out,
out.
right?
Everything is all is a cute product.
And then it's, okay.
I'll have you
All right, guys, let's come back together and we're gonna start here with our middle table. Talk through approaches to dyspnea. Who wants to volunteer from the middle table to talk through their approach?
It's not a smart approach.
All right, guys, we're gonna come together. Sure, Elizabeth, you wanna talk us through your approach to dyspnea? I'd love to hear it.
My, like, not the academic, we talked about there's like the dyspnea experience, but I'm like really bad with that. So I take like a very anatomic approach, like, can the air get in? Do you have like airway problem, obstruction? Do you have a restrictive chest wall? Can't get the air in? Similarly, are you getting the air out? Like COPD, you have to like ventilate those areolas. So get that in. Can, once the air is in there, can it get to the blood vessels, and can the blood get to the alveoli? And that's really kind of how it is. And then is there a problem?
Is there a problem with the what?
Like the blood.
Okay. All right. Table 3, what's your approach?
We talked about the dyspnea pyramids, and how I always have to pull it up.
Yeah.
Because I can't remember it, but it's a very helpful way to make sure you're not missing anything.
Yeah, and let's draw through that together for those who maybe have not seen it before. And so tell me what your categories are.
Oh, gosh, okay, so blood, heart, blood, I feel like are the biggest ones.
Okay.
And then I look at
Okay. Anybody else from table 3 want to jump in? Yeah, so we have renal causes, we have heme causes, cardiac, and then pulm. And so I heard you guys say a couple of things for renal. What were those again?
Respiratory alkalosis or.
So respiratory alkalosis. And then what's our classic metabolic acidosis that we see? Where people might feel dyspneic. Yeah, DKA, they end up on a drip in the ICU. They're trying to breathe off all their carbon dioxide. They're feeling dyspneic. For blood causes, what do you guys think of? Anemia, so no blood. What's the other thing? Popular Taylor Swift song? Bad blood. So that's like you have like carbon dioxide poisoning, hemoglobinemia, things like that. So think about it as no blood or bad blood. What are some cardiac causes of dyspnea? Yep, so we have tamponade. Perfect, MI. Every patient at the VA gets admitted for heart failure, yeah, CHF. And then when, what's one other thing that can cause dyspnea from a cardiac standpoint? Yeah, arrhythmia. Perfect. And then pulmonary, a million things, obviously, right? So let's make some categories here. I think I heard someone say PE. Is that you, Kim?
Yep.
Okay, PE. What else do we got? Pneumonia. Yeah, pneumonia. Give me something a little bit broader.
I mean, like, something like asthma exacerbation, right?
Yeah, so like obstructive disease. So COPD, asthma. What was that? Yeah, pneumothorax. Great. Yeah, ARDS, perfect. Seeing a lot of that now. What does this lady already have? Yeah, effusions. 2 more. Yeah, restrictive physiology. Hemorrhage, yeah, DAH. And then you can think about other things like, when we say pneumonia, you can think of like aspiration versus like bacterial. There's just lots of different ways you can fill in this pyramid, but the idea is that you should have a systematic approach to work through it. Table 1, any other like ways that you guys think of dyspnea or like work through a patient who's coming in with that? System space? Okay. And what systems did you focus on? Okay. Okay, so like neuro, psych, MSK, cards, and any others that you thought of? Heme. Okay. So I think, this is good. We have 3 different approaches to dyspnea, and you guys can use whichever one works for you. I will say that the dyspnea pyramid like just works for my brain. I like thinking of pictures and like things that I can easily cross off. And so that's usually what I do to approach a patient with dyspnea. Karen, you made a very good point earlier in your discussion that I would like you to reiterate to the group. So this patient is presenting with dyspnea, but also with something else.
Oh, hypoxia.
Yeah. So not the same, right? Dyspnea is a symptom that patients describe to you that can be caused by a whole bunch of things. Hypoxia is mediated by different mechanisms, and we can have a conference on this, but you think about like BQ mismatch, you think about like low inspired oxygen, things of that nature. You can see that dyspnea is caused by a much broader array of problems, right? Okay. So with our patient, if we think about the dyspnea pyramid, we've already gotten a couple of studies that can help eliminate things off of this, right? And so what things can we cross off from our dyspnea pyramid with our EKGs, chest x-rays, labs that we have so far? And you guys can just shout them out. Anemia, yeah, so she doesn't have anemia, so she's got enough blood. Yep, no pneumo seen. Yep. Oh, is that one? DAH. Okay, not coughing up any pink frothy sputum or anything. Yeah, it was negative. And no ST segment elevations on her EKGs. Similarly for her EKG, what else can you cross off? Yep, no arrhythmia. I'll tell you that her EF is fine. She had an echo a couple weeks ago, so we'll cross off heart failure. She's not been exposed to any sort of like carbon monoxide situations. So, we'll cross off bad blood. What about her renal status? Did you guys notice like anything particular on her acid base? Everything was pretty normal. So we'll cross those off. And then in terms of her pulmonary status, we know that she has an effusion. So that's a possibility. Pneumonia PE, I think, is still in our differential. She has no obstructive lung disease, so we can cross that off. And then no restrictive physiology either. So we just still have a couple of things that are on our pyramid that we have to sort of work through. And so at each table, tell me what would be the next thing that you would order for this patient? What would you do for your diagnostic workup? And what would you empirically do for treatment for her? So at least 2 more tests that you would do, and then 1 thing that you would do definitively for management at this point, if you're the resident admitting her, and then we'll talk through what they obtained overnight. So take about 1.5 minutes with your groups to do that.
Yeah.
Okay, let's come back together. We're gonna go just in order of the tables. Table one, what is something else you would do for your diagnostic workup with the patient? What's your goal, like the diagnostic you're trying to eliminate? What would you do in the moment to manage her if you're the person that's been in for overnight?
You're gonna get a CTPE.
Great. So CTPE, obviously to rule out a PE. She has a super high elevated dimer. She has history of malignancy. She's tacky. She's hypoxic. If her dimer was low, would you still get the CTPE? Right? Yeah. And her dimer is going to be high no matter what because she has metastatic disease. So like, you shouldn't even check that. You should just get the CTPE. Great. And then what are you going to do in terms of management for her? Yes, let's say like, let's have you answer the question, where do you want her to go? ICU or floor?
So she's still like hemodynamically stable, and so she didn't need nowhere.
Okay, great. Floor with Kelly, love it. Middle table, what's a diagnostic test that you want to do? Okay, yeah, so doing some like a combined diagnostic and management, right? So brain fluid. Yep, and then send some cultures. Just for fluid, anything else that you guys want to culture? Sputum, great. And then what are you going to do to manage her aside from, this draining her fluid? Start antibiotics, fold. Okay, so maybe starting some antibiotics overnight. Yeah, she already has like some abnormalities in terms of her vital signs. She's hypoxic and tacky, no fever, but immunosuppressed. So it's very reasonable to start her on some antibiotics overnight. Table 3, anything different that you guys would do? Okay, what are you looking for in her echo? Okay. All right, well, an echo. Do you have to get an echo if you're worried about cardiac tamponade? Okay, and maybe like what could you do physically? Yeah. Raise your hand if you've done a pulsus paradoxus in your time. Raise your hand if you think that you have done a successful pulsus paradoxus in your time. Okay, 0 100%. Great. We'll talk about this. Okay. All very reasonable management and diagnostic plans. Let me show you what happened overnight for this patient when she was admitted.
Yeah.
And so I'm going to give you her CTPE read. So no large central PE. She's got her moderate left pleural effusion with pleural thickening, a few more nodules in her lungs, which, they say is likely her metastatic disease, a right pleural effusion, a large pericardial effusion, which is increased in size from the previous exam, and these dense opacities in her lungs, which, they're not really sure what it could be, maybe some edema, maybe infection, maybe just atelectasis. Questions, concerns from this CT read? So we've eliminated PE as a diagnosis. What does someone want to do with this new information that we have? You want to call cards? What are you going to ask them to do?
Well, the echo hasn't been done since the weekend.
Yeah, it's nighttime. It's 3 o'clock in the morning, so.
So I would probably have to look at differences between the, they agree that she needs like a better assessment of her function.
Mhm.
Like, work more closely for example, scale. So
Great.
might need to be trained. It's like usually our cardiologist.
Yes. Okay. Sounds good. And I'll be the cardiology fellow, and you've called me to say I'm worried about the pericardial effusion of this patient. And I'm going to say, what's her pulsus? And you're going to say, I haven't done it. And I'm going to hang up on you and say, call me back when it's done. So before we call our cards fellow, we're going to do a pulsus paradoxis on this lady. And what I want you guys to do is break up with your teams and talk about what the exact steps are to do a pulsus. And then we will do one together here in the room and talk through the steps. So talk with your tables. We'll have each table give their description of what they think is the correct order for a pulsus. And then we'll have you guys try it out for each of your tables, and we'll do it with a Doppler so everybody can hear. So I would say take about, let's say 3 minutes. Do you guys think that's enough time or you want more time? Okay, 3 minutes with your teams to come up with the steps for a pulsus paradoxis.
Yeah. I also. No, but I can. under the expiration.
I'll literally like import that. We have that already.
Okay, guys, let's come back together. And so who wants to try first explaining the order of how to do a pulsus paradoxus? We'll do each table, so everybody's gonna get a shot. Table one looks very ready, so I'm gonna, I know you got some eager-looking students with you who I think know what to do.
I'll give it a shot.
Okay, so we're gonna come back together. Table one's gonna give us their directions for how to do a pulsus.
All right, so yeah, get a blood pressure cuff, step one. Put it on, get it. And then when you're listening, you're gonna listen to the first heart sound and then just kind of ignore it, I guess. Keep going down slowly. And then when you hear the second heart sound, kind of intermittently, like 2 heart sounds, 1 heart sound, 2 heart sounds. And that's like the blood pressure will increase with expiration, we think. So you record that when you're first hearing 2 heart sounds, and then you keep going down, and at a certain point, you hear both heart sounds consistently, and that difference is the pulsus. And if it's greater than 10, it's positive.
Okay, middle table, give us your instructions for how you do a pulsus.
So you put a blood pressure cuff on them and get their systolic pressure. I would then take a deep breath and see if the systolic pressure falls back up 10 millimeters from the breathe.
Okay. Third table, your instructions.
Blood pressure cuff on, and measure to over here, but do one measurement with insertion, one measurement with expiration, and then the difference.
Okay.
This is
So
why I love it.
this is a very different consensus. So whenever I think about pulsus, I always go back to my physiology because I think that will really help you solidify the steps that you're looking for. And so I'm going to drop in some pictures for you guys. And so here's a normal heart and a normal, normal pericardium. So for a normal person, you are going to take a breath in. And what happens to our intrathoracic pressure when we take a breath in? Does it become more positive or more negative? Yeah, so intrathoracic pressure becomes more negative when you take a breath in. And so what does that cause? Yeah, so we get greater return of blood into the right side of the heart when we take a breath in, okay? And so that is like what happens in a normal heart. It can come in, go back out like normal when we have nothing with our pericardium that's wrong. Now, let's say that we have a patient with a pericardial effusion. And so this patient has a pericardial effusion, that black thing around their heart. They take a breath in, what happens? Same thing, right? We have a negative intrathoracic pressure. And so negative IT pressure. What does that make happen? Yeah, increases preload. So blood is going to want to still come into the heart. But what's happening now, Steph?
Blood normally can push against the left ventricle for more room. But in this case, because the pericardium has so much fluid, when it pushes against the left ventricle doesn't have any movement, so it makes the left ventricle smaller. So that's why you get increasing your blood pressure.
Yeah, so normally in a normal patient, and I'll draw it in green so it's different, the right ventricle can sort of expand to take on the additional preload that comes in when you take a breath. However, in this case, we have lots of pressure that's built up in the pericardium pushing against the right ventricle. And if you remember, the right ventricle, is it weak or is it strong? It's weak, right? It's a weak bag that just takes blood, doesn't do anything. And so if it can't push against the pericardium, what's going to get pushed on? The septum, right? So the septum will get pushed. And then what does that do to the volume in our left ventricle? It's going to decrease the volume in the left ventricle, meaning that blood pressure drops because cardiac output is dropping. That's why we see the blood pressure go down if someone has a positive pulsus, because the LV has reduced cardiac output. Does that make sense? Okay. So I think for me, it's always super helpful to walk through that physiology, because like I'll forget and be like, oh, I don't, like, what am I supposed to do? Watch someone, they're breathing, something changes, whatever. I don't know. It's positive, call cardiology. And so it's really important to know how to do this, because CARDS is going to ask, because the presence or absence of a pulsus dictates if they have to come in and do a procedure on someone or not. And so it's really important for us to have good information to tell our consultants. And so we have a Doppler here. I recommend that if you guys ever have a patient with a pericardial effusion, instead of using a stethoscope and a manual blood pressure cuff, just use a Doppler in the room, because then everybody can hear at the same time. And so I'll be the model. I'll ask Jason to demonstrate how to do a pulsus, so that way we can practice together. And you guys can see exactly what you have to do. Because I'll say I don't think any of you guys were right, unfortunately, in how you do a pulsus. And that's okay, because this is hard, and unless you do it, it's a skill that you have to build. And unless you practice, it's like very easy to forget.
I just want to point out two quick things really quick. One, it is normal for your blood pressure to drop maybe 1 or 2 points with inspiration, but it's abnormal for it to drop so much. So it'd be better called pulsus exaggeratus as opposed to pulsus paradoxus. It's not paradoxical, it's exaggeration of the normal trend of physiology. And the second point is, yes, it is actually cardiology who does this. We'll take people to the cath lab and do a pericardiocentesis in the cath lab, unless they know window.
Yeah.
So, I love asking people how to do pulsus paradoxus, because everyone says, I'm going to have the patient take a deep breath and hold their breath for 60 seconds while I check their blood pressure. And then I'm going to have them breathe out and hold it out while I check their blood pressure. And it's way easier than that. So before we actually do it, I just want to walk you through what's going to happen. We're going to inflate the blood pressure cuff until we hear no crop cough sounds. So what that means is the pressure in the cuff is so great that no blood can overcome it. Okay?
Our hands should start to go numb. We should leave it like that.
Yep. Okay. Step 2, which is going to be hard to hear in Cassandra's case, because she presumably does not have cardiac tamponade, is we're going to start hearing cough sounds intermittently. So that is the blood intermittently overcoming the pressure of the cuff, but then they'll go away. So what it'll sound like is dun, 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 dun. And if you pay attention to what's happening with Cassandra, that will go away as she is taking a breath and the blood pressure is dropping. Okay. At the point at which we start hearing those intermittent signs, that's our top number. And then as we continue to decrease the cuff, at a certain point we'll hear dun, 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 regardless of what she's doing with her breathing. And when we make that transition, that's the bottom. It's all one continuous linear thing. You don't have to ask the patient to hold their breath. Although you can actually have them hold for a little bit to try to appreciate the difference. Okay? Does that sound a lot easier than what some people might think we have to do? Okay.
And using a Doppler is nice because it requires honesty between yourself and your team. And then actually talk to each other and say like, and then we can say like, you know, this, and say whether your exam was, you know, appropriate or not. I'm a vampire, so. Okay, do you guys hear a normal pulse? Yeah.
This thing leaky?
This cup might be leaking.
Oh. Yeah, we'll try this. Take a deep breath in. So I'm right at around 128. Cassandra's a little nervous, so she has, 128 systolic. And I'm going to stop it right when I start hearing the sounds. Take a deep breath in. The other kind diminish. Oh, you can still hear him. She's going to have a negligible pulseless paradox. Okay. Exhale. Okay, so we're going to pretend that at 1:30 we hear it and then it goes away with inspiration. Okay, and then you keep going down. Take a deep breath in. Still seeing crowd sound. Take a deep breath out. Still hear crowd sound. So when you make that transition, that's the lower number. Top number minus lower number. If it's greater than 10, that's positive. If it's less than 10, that's within normal limits.
Yeah. So next time you guys want to do it, grab a Doppler from your nursing house. And so I'm going to walk you guys through the rest of this case quickly before we wrap up. But this patient actually was pretty interesting. They did a pulses on her and it was negative, but she had an echo that I'm going to show you in just a second. So this was her echo. I'm going to play it for you. And so who wants to tell me where the left ventricle is? I will loop this so that way you guys can keep looking at it. Who feels confident about where the left ventricle is, wants to point it out? Great. Okay. I'm here to help you. So go ahead and draw around the video. Yep, perfect. So that's the left ventricle. Where's the right ventricle? Can you do a take job? Yeah, we go ahead and draw. Yep, so that thing up top is the right ventricle. And what's happening to that chamber on the top?
Along. Accept call.
Yeah, you're pointing out exactly. So the wall of the right ventricle is this thing here. And you can see that it's flowing in.
Yeah.
And this is the pericardial effusion right here. And so this patient actually had regional cardiac tamponade. So she didn't have like a total cardiac tamponade that would cause systemic change in her blood pressure when the pulses was done. But she had regional cardiac tamponade as evidenced by bowing of the right ventricle. And so her was actually very concerned with her tachycardia, dyspnea, bronchial environment, and this echo finding. And she went to the cath lab for pericarditis, had about 500 to 600 cc's of fluid drained. It was malignant, not like in conjunction with her known disease. And the thing that happened afterwards is that you leave the pericardial drain in place for a couple of days. You want the output to be less than about 50 cc's in 24 hours before you think about pulling it. And unfortunately, she kept having reaccumulation. And so that's when you can say, okay, we need to consult CT surgery for a pericardial window that basically makes a space in the pericardium for just drain her flora, so then her thorax catheter can drain. So I hope that this case was illuminating for you guys in a couple of ways. One, we talked about our approaches to dyspnea, kind of the anatomic, a system-based, or the dyspnea pyramid approach. We talked about how to do a pulsus after we saw some imaging findings concerning for a possible pericardial effusion. And we reviewed the physiology with both normal and abnormal pericardial disease, and then saw this echo finding regional target Canada. And that's important contact on. Question.
What happened?
She went home at home hospice, was hurt her window. She was just here actually yesterday. With IR, to have some more of like the brain exchange. For her flare-ups. So, there's been some discussions with Kumaka about changing her chemo regimen, but, she didn't want to engage in any sort of, like, cytotoxic chemotherapy. They recommended paclitaxel. But right now she's on further medicine. She just, Thank you. Okay, thanks, guys. So really, like, the nurse is always happy to Dopplers. If you're ever concerned and you want someone to pulse with you, this is the best way. If you can see that you guys can stay together and do it, you don't have to have one pressure cuff, your stethoscope, and just grab the Doppler.